And frequently we see that the eye care is not integrated very well into the health system, probably because of the fact that it does not cause mortality. Now, the recommendations of the World Health Organization include the fact that we must make eye care an integral part of hospital coverage. We should implement integrated people-centered eye care in health systems. We should promote high-quality implementation and health systems research for effective eye care intervention. Monitor the trend and evaluate progress toward implementing integrated people-centered eye care. And
so I think you're ready. You can begin now.
Okay, good morning, everybody.
Morning.
I see that. My name is Dr. Gundo, and we'll be moderating this session with Dr. Kahaki Kimani. And I think Daktari would like to take the session first.
Good morning, everybody. Welcome to this session on panel discussion on the sessions that I'm hoping that people have gone through on the public health eye care. We'll be happy to accept any questions, comments, discussions. We are hoping that this will be a lively discussion. So welcome, everyone. It's a 30-minute session. We are hoping there'll be enough material generated to discuss, otherwise it will be a very long session. Welcome.
So maybe as we wait for the questions to start coming in, we can look at some of the questions that were typed earlier in the chat. Dr. Puri had asked, what are the community approaches being undertaken to improve compliance? This was in relation to diabetic retinopathy screening. And I think she meant the question would be with regards to the study done in Bagathi, as well as the one done at Kwale Eye Center about follow-up of patients after diabetic retinopathy screening. So I don't think we have policies or protocols yet. We have seen from the studies that were presented, Dr. Nyawira's study, for example, where cost is something that is a big issue for our clients. And that might be one of the reasons why we have poor compliance with something like diabetic retinopathy, which we understand is a pretty expensive disease to treat. So I think that's one of the areas of research that I think was also recommended in Kwamboka's study with regard to finding out the different barriers as to why patients are not complying with treatment. So I suspect cost may be one of them, but I do think we do need to do more, particularly qualitative studies, so as to find out what are the other barriers our patients or our clients could be encountering. I think Okwama also asked, how best do we undertake screening of diabetic retinopathy in low and middle income countries, especially with limited access to fundus cameras? And I think Dr. Nyawira had already answered that on the chat, but maybe for the others who would be interested in knowing the answer to that question. So she mentioned that the guidelines do recommend that we use whatever resources we have. So we still have direct ophthalmoscopes, we have indirect ophthalmoscopes, you have your slit lamp. So you do not need a fundus camera in order for you to do diabetic retinopathy screening. You can use whichever implements you have at hand, even as you plan for the more effective tool, the fundus camera. Okay. So just feel free to type your questions in the chat if you have anything that you would like us to address.
Maybe one of the other things
Um,
I wanted to comment on was on Dr. Gishangi's presentation on the World Vision report, which I found very interesting. But one of the things I noticed that we are always talking about improving, especially primary eye care, because I think that's the backbone of improving our eye care. And I feel probably we should consider making primary eye care an integral part of every curriculum that deals with training of primary healthcare workers, so that at least everybody has some basic knowledge on how to deal with simple ocular conditions. As we have seen in some of the presentations, especially like the one by Dr. Rono, things like allergic conjunctivitis always form the bulk of people seeking eye care. And if it could be dealt with at the primary healthcare level, then they don't need to travel all the way to a level 5 hospital just for allergic conjunctivitis. Yeah, that was just my suggestion. So that in every curriculum that deals with primary healthcare, there is a component of primary eye care.
Right, I completely agree because it is actually an important community how to say aspect, the eye care, because a lot of people seem to think that eye care is more of a privilege. And I think one of the comments in the chat had been that maybe we should stop calling it eye care and call it eye health, so that people don't feel that it is a special treatment that you go to a special hospital for, but it is just like nutrition, it is like maternal and child health, things that are part of our daily life, so that even right from the grandmother in the village right up to the university graduate is aware that they need to take care of their eyes, and there are things that can be done at the local dispensary or the local clinic to help them with regard to their eye health. And I think this is maybe an important direction that eye health is taking in Kenya, that we're starting to realize that community ophthalmology is also part of ophthalmology, and not everyone should be a VR surgeon or, you know, a specialist in terms of surgical fields, but even ophthalmologists and eye care workers are supposed to be engaging in.
I completely agree. It's interesting that you bring in the component of even changing the terminology, because actually, you're right. I think terminology or the way something is put already sets people in a certain frame of mind. So when you say care, maybe they think it's like a special thing. But when you call it health, then maybe everybody will identify with it. Yeah, so I completely agree with you.
I see Dr. Nyawera has asked, what do we need to do about the non-blinding eye conditions that contribute to high ocular morbidity and healthcare costs? Do you have any suggestions?
Well, I think that's a very pertinent question, because actually, as we saw from the ocular morbidity study in Bere, most of the eye conditions are not blinding. And in fact, one of the main reasons we decided to do that study is because we realized most researches that are done on eye problems, they usually deal with the blinding conditions. And yet, even the non-blinding conditions, they take away from the quality of life. For example, if it is allergic conjunctivitis, children will miss school because the eyes are very sensitive to light, or they are very red and they have to be taken to the hospital. So it still takes away from their quality of life. And I think one of the recommendations we made from that study is that there should be a focus also on dealing with those non-blinding conditions. And maybe even as I was mentioning earlier, making our curriculum on primary healthcare have eye care or eye health as part of it would go a long way in dealing with these non-blinding eye conditions, which actually cause a lot of problems to people, even things like presbyopia. I think that can be dealt with even at a health center if the health provider is equipped to deal with it. So yeah, I think maybe Dr. Cynthia, you'd want to add something?
I think that's really important, and I think that's a challenge for us as the team leads in the eye care team, because integrating the primary eye care into primary health, I think is going to have to come from us. We're the ones who are going to have to advocate for it and push for it to happen at all levels, because you realize most other people don't really know anything about the eye beyond the fact that it helps them see things. And I think it will be up to us to even help them develop the material and the curriculum, and to advocate and push for it to be included in the various primary healthcare curricula around the country. And I think that's something that we need to start with now, as people are beginning to realize more and more the importance of community ophthalmology and just primary eye care. We are going back to the basics. Even things like maternal health is being taken right down to the grassroots. So we should follow suit and make sure we are not left behind. If we say that universal health coverage includes eye care, then we really need to translate that into reality. It should not just be a slogan we're saying, but it should be something that we see happening. So I think advocating for like NHIF cover for eye services, those are things that we're going to need to work at. And I think that's part of what Dr. Gishangi was mentioning with the national strategic plan that he spoke about yesterday. So I think those are the things that we should be gearing to work at and encouraging, especially the upcoming classes, the trainees. We should start sensitizing them to that even while they're in training. Okay, so I'm hoping the reason we're not seeing questions is because people are visiting the exhibitors and speaking to them. They've put quite a lot into this. Their sponsors have been very helpful. So I hope that's the reason people are still engaging with them, and we shall get a few more questions in the next few minutes.
I can see we have 16 participants, and I'm really looking forward to them saying something, even if it's just a comment, even if it's just to say hello, so that we know you're there.
On the chat, I'm seeing Dr. Gishangi has asked whether we would say that diabetic patients going to Mbagathi Hospital are able to access diabetic retinopathy services now that only 280 out of the approximately 2,000 patients were evaluated. I think access to diabetic retinopathy services might still not be quite where we would like it to be. Because when you say diabetic retinopathy services, I'm sure you don't just mean the screening. I'm presuming you mean that this is the whole continuum of care, which we are now encouraging when we talk about integrated patient-centered eye care. So right from promotive to curative services. Unfortunately, we do not have the entire range of services available at Mbagathi yet. So when the screening is done for some of the treatment, for example, like those patients who would need laser, those are patients who would still need to be referred. So I think in answer to your question, I would not say that diabetic patients have adequate access to diabetic retinopathy services. And those are some of the challenges that we would be working on in, going forward in future, seeing that Dr. Mora's study has actually come up with a number of very good recommendations, which we hope to use to advocate for better services for our clients within the county. I don't know if maybe at Kenyatta Hospital, you would say the access for diabetic retinopathy services is better than at Mbagathi. What do you think, Daktari?
I really don't know. I think in Kenyatta, I don't deal much with diabetic retinopathy services, but I guess we are advantaged in that we have, in terms of the human resource capacity, we have a lot, especially because of our residents. And so every week we always have like a list for laser, for intravitreal injections. I'm sure we could make it better, because for me, what I believe is a patient should not be rebooked. If they have come all the way, they should not be rebooked to come back for an injection or for laser. I wish it was possible the day they appear is the same day that they get the service, because I think I think it was Lillian who presented a study from Kwale that showed that many of them don't come back. So if you see them and you give them another appointment, they might not come back. Yeah, yeah. I can see Lillian is with us, and I just want to congratulate her for that presentation. I really enjoyed it.
Okay. I think maybe just to refresh your memories, if you're looking for questions to ask us, we talked a lot about diabetes, diabetic retinopathy in particular. We talked about treatment using one vial for multiple patients, and we've seen that there is no published data from Africa, let alone Kenya. And I think this should be a challenge to us, because we do this work. I know people are receiving anti-VEGF treatment in Kenya. So maybe we should take a few minutes out of our busy schedules and, you know, jot something down so that next time somebody does a scoping review or a rapid review, at least 1 or 2 papers will be there from Kenya. We've also talked about utilization of eye care services, and we've mentioned repeatedly today just how important primary eye care is. So I hope that's one of the messages we'll be taking with us going forward, just championing primary eye care inclusion in primary healthcare. And we've talked about the patient pathway, and we realize there are a number of barriers that our clients face, and we should also start thinking about ways of removing these barriers so that our patients can access the care that they need.
There was also the presentation from Baraza on trachoma and the evaluation that has taken place. And I can see Professor Karimuri has commented that trachoma is now integrated into NTDs. But for me, I must say, it's so disappointing to see that even though many of the ultimate goals had been met, when you look at the core that would help us eliminate trachoma, like face washing and access to water, it's still, I think it was like 1 out of the 52 intervention units, which is, honestly, it means that we will just be going around in circles until we address that the environmental component. We can forget about eliminating trachoma. And so probably the same way when they talk about electricity, they talk about the last mile. I think we should also be talking about the last mile when it comes to access to water, because I think that is all we need probably for trachoma, and we would go a long way. As Professor Karimuri has commented, he says we need a change in attitude, and probably it is not just attitude, but also altitude. We must take ourselves to a higher level. Yeah.
I completely agree, because I think one of the things that has happened with eye care is that we have been siloed for very long, because some things like WASH, for example, we really should be in talks with the Ministry of Environment, for example, because they're the ones who are actually going to help us push for that clean running water to get to that last mile. And I think we need to start getting out of our small box and start talking to people in other areas to help us achieve some of these goals. Because by ourselves, we are not going to be able to provide water, we're not going to be able to provide those latrines, and we can't keep relying on the NGOs forever. So I think it's time we started talking to other branches of government and get them interested, because it would be a win-win for both of us. If they can meet their targets of getting water somewhere, they win because they look good, and we win because we reduce trachoma and other such diseases in the environment. So I agree with Professor Karimuri. We do need a change of attitude, and we also need to start engaging more with our counterparts in different departments. And I see Dr. Gishangi is also agreeing with us. He says the cost of primary healthcare interventions are very low compared to the returns on investment. So yes, we do need to go that last mile.
Please keep the comments coming so that we have something to discuss.
We have another comment here on the from the utilization of secondary eye services. Dr. Gishangi says a nurse at the dispensary should be able to treat some eye diseases, like a sty should not have to make its way to a level 5 hospital. So again, just the importance of the primary eye care services being delivered at primary level, because you find we're delivering at level. So Dr. Choksi was there any data collected from the private sector? Yes, trachoma cannot be eradicated but eliminated, and most of our data and information is community-based. The contribution of the private practitioners and hospitals is minimal, but recognized where it is reported. So we still need quite some advocacy within the private sector.
Maybe I just also wanted to add on to that. Actually, trachoma is a public health problem, but manifests in the eyes. So I think even if we look at the private sector supporting the work on trachoma, I think we need so much more at very high levels. At very high levels, we need a lot of goodwill from the top, because I think we all know why trachoma is endemic in certain areas, and we know that trachoma equals poverty. So if you can deal with the issues that make these places so poor that they cannot access what they need in order to avoid contracting trachoma, then it's so difficult to deal with it. We can keep talking about mass treatment with antibiotics, but that is just like putting an elastoplast on a huge gaping wound. Yeah.
I can't see any more questions on the various chats. So I think we've dealt with everything that has been raised so far. We have about 3 minutes. I don't know whether there's anybody who wants to make a last comment, or people are rushing to see the exhibitors before we wind up today's session.
Okay, so I think I just want to take this opportunity to really thank all the presenters. I think I enjoyed each and every presentation. And I think we still have, I think it just shows us we have a lot of opportunities, especially for research. And we also have a lot of opportunities to do more for public eye health. And I hope through this, everybody is motivated and energized with new energy to go out there and do whatever it takes to make it better for Kenyans in terms of eye care. Thank you very much.
I'd also like to thank all the presenters. I think they did an excellent job, and like Dr. said, they were very captivating presentations. I think for me, maybe one thing I would like to point out is that in public health is where we seem to come and gel together as the eye care team. We've seen presentations from students, we've seen presentations from clinical officers, we've seen presentations from ophthalmologists. We're just missing a nurse. So maybe next year we will also have a nurse presenting for us and just, showcasing how as a team we can achieve more, and we're able to just go further with ophthalmology and, just getting better healthcare for our patients. Thank you so much everyone for attending. Thank you so much, Daktari, for leading this session. And we hope you can enjoy the rest of the conference. Yeah.
Thank you, Cynthia. I think you made it more interesting. Yeah, thank you. Wishing everybody a great weekend.